Good morning, everyone, and welcome. I'm Dr. Asim Hussein, and today we'll be discussing endocrine and metabolic emergencies. Specifically, we'll focus on myxedema coma. Over the next few minutes, I'll guide you through the key aspects of this critical condition, including its presentation, diagnosis, and management. Let's get started. Let's walk through the key points here. We have a 78-year-old woman with long-standing hypothyroidism who is now presenting with some serious symptoms. She's drowsy, which indicates altered mental status, and she's hypothermic at 33 degrees Celsius, which is dangerously low. Her heart rate is bradycardic at 44 beats per minute, and she's hypotensive, meaning her blood pressure is low. Additionally, she's experiencing hypoventilation and CO2 retention, suggesting that her breathing is inadequate. These signs point toward a severe hypothyroid state, possibly myxedema coma, which is a medical emergency. Immediate management needs to be focused on stabilizing her condition quickly. Now, when we look at the options, the most critical initial step is to address her hypothermia and stabilize her vitals. Option A suggests giving a large bolus of IV levothyroxine immediately, but that's not the first step in an emergency scenario like this. We need to stabilize her cardiovascular and respiratory functions first. Option B recommends giving IV hydrocortisone before thyroid hormone, which is important if adrenal insufficiency is suspected. But again, the priority here is to stabilize her airway, breathing, and circulation. Option C involves active external cooling, but in this case, she's hypothermic, so cooling would be dangerous. Option D is giving oral liothyronine, but oral administration isn't suitable in such a critically ill patient who might be unconscious or unable to swallow. Finally, option E is to observe and recheck vitals in 4 hours, but waiting that long could be too late given her unstable condition. The most appropriate immediate action is to actively manage her hypothermia and support her vitals now. That's why the correct choice here is to initiate active external cooling. Wait, actually, in this scenario, external cooling is not appropriate because she's hypothermic. So instead, the immediate priority is to prevent further heat loss and stabilize her while preparing for definitive treatment. Therefore, the best answer from these options, considering the critical nature, is actually to support her vital functions promptly. Though that exact action isn't listed here, the key is to recognize that stabilization is the first step. In the context of this slide, the best immediate action among the options provided is to give IV hydrocortisone before thyroid hormone, since that helps address potential adrenal insufficiency, which can coexist with severe hypothyroidism and complicate management. So remember, in severe hypothyroid emergencies, supporting vital functions and considering corticosteroids is a priority before definitive thyroid hormone therapy. Alright, so when we're suspecting myxedema coma, the correct initial step is to give IV hydrocortisone at 100 mg. This is crucial because it helps cover the possibility of adrenal insufficiency, which can often coexist with severe hypothyroidism. Once we've addressed that, we can safely move on to thyroid hormone replacement, typically starting with IV T4 and sometimes adding a small dose of T3 if needed. It's also very important to remember that supportive care is key, so ensuring airway and ventilation support is in place, along with passive and slow rewarming. These steps are essential to stabilize the patient before we proceed with definitive thyroid treatment. Overall, the focus here is on careful, stepwise management to mitigate risks and support the patient through this critical condition. Alright, let's look at the options for managing severe myxedema coma after administering hydrocortisone. The key here is to understand what the most effective thyroid hormone regimen is in this critical situation. Option A suggests giving a high-dose IV T3, specifically 0.5 micrograms per kilogram as a bolus. While T3 acts quickly, it's often associated with more cardiac stress and may not be the best initial choice. Option B recommends an IV loading dose of levothyroxine, around 200 to 300 micrograms, followed by a maintenance dose of 50 to 100 micrograms daily, with or without low-dose T3. This approach provides a steady and controlled correction of thyroid hormone levels, which is generally safer and more effective in severe cases. Option C involves giving oral levothyroxine only once the patient is awake. While oral therapy is simpler, it's not suitable in severe myxedema coma because absorption can be unpredictable, and the patient may not be able to swallow or absorb the medication effectively. Option D suggests no hormone therapy and only supportive care. While supportive care is essential, hormone replacement is critical for recovery, so this approach isn't advisable as the sole intervention. Finally, option E involves giving PTU to block thyroid hormone synthesis. PTU is useful in cases of thyroid storm, but in myxedema coma, the primary goal is to replace deficient hormones, making this option less appropriate. So, in this scenario, the most recommended approach after hydrocortisone is to give IV levothyroxine with a loading dose followed by maintenance, as it provides a controlled and effective way to restore thyroid function safely. The correct answer here is B when managing this situation. A typical approach involves starting with an IV T4 loading dose, usually between 200 to 400 micrograms. After that, we follow up with a daily IV T4 dose, which generally ranges from 50 to 100 micrograms. Sometimes, in a monitored setting, a small dose of T3 can be added, but it's important to be cautious because T3 can increase the risk of arrhythmias. It's crucial to avoid giving excessive or rapid doses of T3, as that can lead to complications. Overall, this strategy helps ensure safe and effective thyroid hormone replacement, especially in critical situations. This approach aligns with our goal of carefully balancing hormone levels while minimizing risks. When managing hypothermia in a myxedema patient with a temperature of 32.8 degrees C, it's crucial to select the appropriate rewarming technique. Now, looking at the options on this slide, the key concept is to choose a method that's safe and effective without causing additional stress or complications. Option A involves rapid active external warming with forced hot air to 38 degrees C, but this can sometimes lead to afterdrop, where the core temperature drops further as cold blood from the periphery returns to the core. So, this isn't usually the preferred approach in moderate hypothermia cases like ours. Option C, immersion in hot water baths, might seem quick, but it can be too aggressive and risky, especially for patients with underlying conditions like myxedema. Option D, induced therapeutic hypothermia, is actually a treatment used in specific situations like cardiac arrest, not for rewarming hypothermic patients, so it's not relevant here. Option E, immediate peritoneal dialysis warming, is generally reserved for severe cases involving renal failure, and it's not the first-line approach for moderate hypothermia. This leaves us with option B, passive slow rewarming with blankets and ambient warmth, along with treating the underlying cause, which is hypothyroidism in this case. This method is gentle, reduces risk of complications, and allows the body's natural mechanisms to rewarm gradually. So, in summary, for a myxedema patient with hypothermia at 32.8 degrees C, the most appropriate choice is passive, slow rewarming combined with addressing the underlying hypothyroidism. This approach aligns with the overall principles of safe hypothermia management, emphasizing gradual rewarming and treating the root cause. The correct answer here is B now. Let's talk about why that's the case. When rewarming a patient, it's crucial to do it slowly and passively. This approach helps us avoid vasodilatation, which can lead to significant hypotension. Rapid rewarming or active measures, like using hot packs or heating devices, should be used cautiously. If we rewarm too quickly, we risk causing sudden vasodilation, which can destabilize the patient's blood pressure. So, the key takeaway is that a gentle, controlled rewarming process is safest and most effective in preventing complications. This principle ties back to the overall goal of managing hypothermia carefully to avoid further physiological stress. Now, let's look at this question about a myxedema patient with a sodium level of 120 mmol/L. The question asks us to identify the most likely mechanism behind this hyponatremia. First, it's important to remember that hyponatremia in hypothyroidism, especially myxedema, is often due to impaired water clearance. When thyroid hormone levels are low, the body's ability to excrete free water decreases, leading to water retention and dilution of sodium. Among the options, the most fitting one is related to SIADH, or syndrome of inappropriate antidiuretic hormone secretion, which can be triggered by hypothyroidism. This causes an increase in water reabsorption in the kidneys, diluting the sodium in the blood. This mechanism is quite distinct from other causes like excessive sodium intake or diuretic overdose, which tend to cause different electrolyte disturbances. So the key concept here is that hypothyroidism can lead to SIADH-like conditions, resulting in decreased free water clearance and subsequent hyponatremia. Understanding this connection helps us see how endocrine disorders can influence fluid and electrolyte balance, which ties into the broader theme of how hormonal regulation impacts homeostasis. The correct answer here is C now. Let's break down what that means. Hypothyroidism, as many of you know, can lead to a condition called dilutional hyponatremia. Essentially, this happens because the decreased thyroid hormone levels cause a reduction in free water clearance. When the body can't get rid of excess water effectively, it dilutes the sodium in the bloodstream, leading to hyponatremia. Additionally, hypothyroidism can sometimes mimic a syndrome called SIADH, or syndrome of inappropriate antidiuretic hormone secretion. In this scenario, the body inappropriately retains water, further diluting the sodium levels. So the key takeaway is that hypothyroidism can cause hyponatremia primarily through these mechanisms: decreased water clearance, and at times, a SIADH-like picture. This understanding helps us see how thyroid function directly influences water and sodium balance, which is central to our overall discussion on electrolyte disturbances. All right, let's focus on the critical management step in myxedema coma. The question here asks, which ICU measure is most important to implement promptly? The options include early intubation and ventilatory support, immediate dialysis, high-dose loop diuretics, immediate IV insulin infusion, and therapeutic plasma exchange. Now, the key concept to understand is that myxedema coma is a severe, life-threatening hypothyroid state. It often presents with hypoventilation, decreased mental status, and multisystem involvement. The most urgent intervention is to support vital functions, especially breathing. So, among these choices, the most critical to act on immediately is early intubation and ventilatory support if the patient is hypoventilating. Ensuring adequate oxygenation and ventilation is paramount because respiratory failure can rapidly lead to deterioration. While other options, like dialysis or plasma exchange, might be relevant in specific contexts, they are not the first-line emergency measures in this scenario. Insulin infusion is more relevant for diabetic ketoacidosis, which isn't the primary concern here. Therefore, the most crucial action is to secure the airway and provide ventilatory support promptly if needed. This aligns with the overall theme of stabilizing vital functions as the top priority in managing myxedema coma. The correct answer here is A now. Let's talk about why airway and ventilatory support are so crucial in this context. Hypoventilation and CO2 retention are common issues that can lead to deterioration if not managed properly. When a patient isn't ventilating effectively, carbon dioxide builds up in the body, which can cause significant problems. Supporting the airway and ensuring proper ventilation helps to prevent this buildup and stabilizes the patient's condition. In addition to ventilatory support, supportive care plays a vital role. This includes hormone replacement to address any hormonal deficiencies and steroids to reduce inflammation and immune responses. These are the mainstays of treatment because they target the underlying issues and help the patient recover more effectively. Connecting this to our overall theme, It's clear that managing airway and ventilation issues promptly is essential to prevent deterioration, especially in conditions that affect respiratory function. This integrated approach ensures we're not just treating symptoms, but also supporting the body's recovery process. When managing myxedema coma, it's crucial to recognize the key clinical features such as hypothermia, bradycardia, hypoventilation, hypotension, hypoglycemia, hyponatremia, and altered mental state. These signs highlight the severity of the condition and guide our immediate priorities. First, we need to secure the ABCs, airway, breathing, and circulation. If necessary, intubation should be performed promptly to ensure adequate ventilation. Administering IV hydrocortisone is essential to cover potential adrenal insufficiency, which often coexists in these critically ill patients. Along with that, we give IV levothyroxine, starting with a loading dose followed by maintenance therapy, to replace the deficient thyroid hormone. In selected patients, cautious low-dose T3 can be considered, but we must be careful to avoid rapid changes. Passive, slow rewarming is important. Aggressive warming can cause complications, so gentle rewarming is preferred. We also need to correct electrolyte abnormalities and identify any precipitants that triggered the crisis. Most importantly, avoid rapid warming or giving high doses of T3, as these can increase the risk of arrhythmias or ischemia. The overall goal is to stabilize the patient carefully while addressing the underlying hypothyroid crisis. Thank you so much for your time and attention today. I really appreciate the opportunity to share these insights with you. If there's one key takeaway I want you to remember, it's that understanding these concepts can truly make a difference in how we approach our work and our goals. Throughout this presentation, we've explored how these ideas connect to the bigger picture of innovation and growth. I hope you feel inspired to apply what you've learned and to continue exploring these topics further. Once again, thank you for being such an engaged audience. I look forward to seeing how you take this knowledge forward.